So, Joel Dunning here at CTSNet, and I'm absolutely delighted to be with one of my absolute heroes, Bob Cerfolio, a fantastic surgeon many times, but we're here to talk about an incredible achievement. On the 29th of July, there was a News and World Report. Every single year, they metric all the units in the whole of America. And really, for the very, very first time, NYU Langone, where you have been involved very heavily in the management for 7 years, has come top in the whole USA, not only in heart surgery, but also in thoracic surgery. You're on top of the world. This is no accident. This is a huge amount of effort. This is incredible. And this is what we'd like to talk to you about. So first of all, sir, thanks for coming on. Congratulations. And tell us a little bit about the 7-year journey that put you on top of the world.
Yeah, I appreciate that. And first, I want to make it clear that it's not my journey, obviously. It's the journey of all the 25, 30 surgeons here at NYU that do heart and lung surgery. You know, our chair, Ralph Mosca, is an incredible guy. He gets a huge amount of credit. Aubrey Galloway, who was a chair who got a lot of the people here, gets an enormous amount of credit, as Dr. Galloway really brought a culture 10 or 15, 20 years ago, bringing specialists. Our dean and CEO, Dr. Grossman, and all the other surgeons and doctors and PAs. This is a real credit to the team. Yeah, I did get here 8 years ago, and we were ranked like 26th in lung surgery. And when I got here, we were, keeping people in the hospital 3-4 days, keeping chest tubes in for a day or two, using Foley catheters, A-lines, and doing some things that, we weren't doing in Alabama. And then I think we found, world-class surgeons like Dr. Zervos and Michael Zervos, who's here as a world-class robotic surgeon, and other surgeons. And we tried to fix our processes. And really, I think great outcomes are secondary to, first of all, having the right people in the right place at the right purpose. 3 of the P's. When you're a doctor, the purpose is easy. It's to make people better. But having the right people in the right place isn't. When I came in as, chief of thoracic, we had to make some changes there. And then we had to start measuring what's best in class and measure things that matter. Administrators love to give doctors report cards and they measure things that are idiotic. I mean, absolutely idiotic. Or they don't understand risk stratifications, or that what one doctor's doing is completely different from another. So we created the EQI, the Efficiency Quality Index, something I created when I was in Alabama, that only measures things that really matter, measures things that are real surrogate of quality. We let the doctors tell us what is quality metrics for procedure X, Y, and Z. We still, I was COO for 4 years during this time, and an executive vice president and vice dean of the medical school. We still had to give you our metrics of your cost, your length of stay, your 30, 90-day mortality, your readmissions, what time people were discharged, all that matters. So you got your administrative metrics, but we let the doctors tell us what was the quality metrics of, say, of robotic lobectomy, which is R0 resection, operative time, how much blood loss you had, how many N2 stations you removed, how many N1 stations, how many total lymph nodes, how many days in the hospital, which should always only be 23 hours. What was the time the chest tube was in? What the readmission rate is, what's the patient satisfaction, what were your teaching scores with the residents and fellows. What is your citizenship scores to the nurses. These are all things we measured objectively. Each one of those gets a number, it's scored, and then we meet quarterly with all the members of the division, and we say, hey, here's the top performer, why is he or she better than you? And we drove everybody to drive to that outcome by changing their process. For instance, sending people home with the chest tube and a digital air leak system. When I got here, we didn't have digital air leaks. They had analogs. They were using A-lines. We were using Foleys. We were sending some people to the ICU after a lobectomy. A robot wasn't being done on everybody like it is now. So these are the processes that we changed. I hope that gives you a condensed answer to what's really a complex question.
And you've done it in heart surgery as well. So give us a few examples about what you are metricing in heart surgery to make you number one.
Yeah, and again, this comes down to the doctors get credit. This is Elias Diaz. Dr. Diaz gets all the credit for this, because when we first started talking about EQI, he quickly said, hey, this makes sense. And he took the EQI and ran with it. He said we should use all arterial grafts. We should revascularize everybody and make sure that that's done. It's not just the STS looking at, do you have a beta blocker or do they go home with this or that? But it's more granular things. Coronary should only be in the hospital 3 days, not 7. They should all get extubated in the operating room, not the next day. Their drain should be out in a day, not 3 days. It is crazy to me that there's people listening who still report volume of chest tube output in lung surgery. You and I know it's complete buffoonery. It makes no sense. Yet I still go to meetings and hear doctors say, oh, I can't take that tube out. I put out 400 cc's last night. It doesn't even make sense when we're pulling chest tubes out in the OR in 60% of our lobes and segments, and within 2 or 4 hours in 95% of our lobes and segments. We all know volume doesn't matter, and the cardiac surgeon is realizing that as well too. Of course, bleeding's a different issue, but Dr. Eliasius is removing his tubes within a day or two. And then you have to take the work you do in the hospital when they go home on the 3rd day, and now it all gets shifted to the outpatient. So you have to communicate with the patients daily. I give everybody my cell phone. He has the patients come in the office for a few days, weighs them, goes over things. He's constantly in contact with them, but they're not in the hospital. What's the benefit to that? Well, the hospital is the worst thing in the world for patients. They get confused. They get the wrong medicines. They get nosocomial infections. They get woken up when they're trying to sleep. They can't take the pain medicine because the nurse says you have to wait another 7 minutes. It's a terrible place to be. So the quicker you leave the hospital, the better for 99% of people. But then you have to take care of them at home. So we've just, leveraged technology, pulse oximeters. I have a Whoop on. Some people have a Apple Watch. They can send me their EKG and I can tell them if they're in AFib or not. I can see their pulse ox. So my patients all go home on post-op day 1 in the morning at 8 a.m., 23-hour admission. They go home and they send me a picture twice a day of their pulse oximeter and their readings. Some of them have cardiac index now in the pulse oximeters. It's unbelievable. So you can get a cardiac index and their sat and heart rate and a temperature. And that's much better at being at home. It's more work for me, but it allows us to take care of a lot more people who have cancer instead of some lady sitting in bed on postoperative day 3 eating eggs and bacon who's got no reason to be in that hospital, denying someone in the ER getting a bed, or a heart patient in a recovery room who can't get a bed because someone's up there unnecessarily. So all of this spins into better care and better economics for the healthcare system.
These rankings are rated over 800 heart hospitals. They have recently changed their metrics a little bit, and they made the metrics more patient-focused. So to what extent do you think the reason you've become top is because they've started metricing what you've always metriced, or did you change to what they metric? What were your thoughts on how you've paired up nicely with this new ranking that they do?
So it's combined. We obviously shoot for the targets that are out there. U.S. News and World Report was always important to us, but so are our contracts with private payers. So when I was COO and executive VP, I had a giant board with targets on them. And the targets for dermatology are different than the targets for psychiatry, difference for cardiac, thoracic, and neurosurgery. But U.S. News and World Report was a big target. And, if the surrogates of quality are really quality surrogates, we shoot to them. If there's something silly, then we don't. We won this by our 30 and 90-day mortality. You can't lie and cheat. People either are dead or alive. That's a pretty binary formula for 30 and 90-day mortality. You can't cheat on readmissions because they come to the hospital and they do or they don't. And you can't cheat on patient experience because these are subjective forms given to patients. So we really did work very hard on patient experience. I'm very passionate about it. I've been giving I've been giving my patients my cell phone for 20 years. When I was COO, I wanted to mandate it. I got told by HR that was illegal. Okay, I went too far, but I tried. But I think if every doctor gave their cell phone, here's the big benefit. Most patients don't abuse it. I'm in New York City. They told me I couldn't do it here. We did it here. The people who abuse it, you tell them that, and then you take away the privilege. I've only had to do that with one patient, and I've done 20,300 operations, 3,009 robots, one patient. It acts as an early warning signal, and if we just listen, this is why our patients don't die. They send me a pulse ox, and they say, hey, doc, I used to be 98. Now I'm 89. My heart rate used to be 90. Now I'm 120. Something's wrong. And I got this a few weeks ago from a guy 14, 15 days after surgery. He had stopped giving me texts after 3 days. And I'm like, listen, something's wrong. We got him in the ER. He's having a problem completely unrelated to lung surgery, but he was sick and septic and actually had a colitis. in his descending colon, diverticulitis. And so this warning signal picked it up and probably saved him a perf. And it saved us pneumonias and AFibs and other things. So I think if you stay in contact with your patient, not only do they love you better, not only do you care for them better, you can't fake caring, but you get objective measurements of what's really happening at home and bring people in sooner than they call your office, they leave a message, they talk to a resident intern, says, hey, you're probably okay. Or everyone says go to the ER in the United States to cover themselves medically, legally, but that's bad care and bad experience to go to the ER for 12 hours. But, I think the credit for all this, Joel, is really to the whole team and the whole university. I mean, Dr. Grossman, when he got here, he had metrics and dashboards, and he started measuring this in real time. And that's $1 million infrastructure. So really, it starts at the top with the CEO, Grossman, who had metrics and dashboards. Then a chair like Aubrey Galloway, who said, I'm going to get an expert in every field of cardiac. He's got, Didier, Dr. Didier, who does, Dr. Didier Lumet, who does our robotic mitral valve. That's all he does. We have Matt Williams, only does TAVRs and complex aortic stuff. We have Mark Peterson, who just does aortic aneurysms. We have Dr. Elias, Elias Zias, who just does coronary artery bypass grafting. The list goes on and on. We have Stephanie Chang, who does lung transplant and robotic surgery, and now robotic lung transplant. We have Michael Zervos, who's maybe the best robotic surgeon or best thoracic surgeon in the world, who does SP, XI, in complex intrapericardial resections after chemo and immuno. Every day he's got a chemo immuno patient. And the list goes on and on. We have, Kostas Bazikas, who just does all our esophageal work. So we have an expert in every little field as we go along. And that's the vision of Dr. Ralph Mosca and Dr. Aubrey Galloway and our chairs and everybody to really help us to do this. Without the people, you can't do it. You can have great processes, but you have to have the right people in the right place and the right process and the right purpose.
I might be honest, I didn't 100% believe all your patients were going home the next day.
Right.
And you did him, and I thought, this patient is never going out. 89 she was, and I watched her leave. She didn't leave at 8 o'clock. She left at 8:50. You said
she
they
was
all leave at
15
8.
minutes late. Well, we wrote her up. She was 15 minutes late. There's a reason for that. Number one, we give them the medicines to the beds, called meds to beds, before they leave. Two, if there's a problem, they have all day to get what they need from the pharmacy, not going home at 3 in the afternoon. Three, it allows people from the ER to get beds and people in the operating room not to be held up out of the OR because someone's in recovery because there's no beds. So as a COO that ran a healthcare system, I know that those problems, and people get out of the hospital much quicker at 8 because there aren't any lines to get out. At 10 or 11, New York City, the cars are packed on our First Ave. So it's better for patients. It's better for their health. It's better for their experience, and it's better for our healthcare system. So all my people leave at 8 a.m. It's better for them.
And I know your thoracic practice really well. 70% of the people watching will be cardiac surgeons.
Yes.
I don't have a really good understanding of how much you can push that in cardiac surgery. So I know you've got a lot of them doing WhatsApp groups. I know you've got extubation on table, minimally invasive, walking. But what else can you do for cardiac? What day can you get them out? Do you worry about atrial fibrillation, late tamponade? When do the pacing wires come out? Have you changed all that?
We've changed all of it, because to say I worry about AFib, then you should keep the patient in the hospital for 31 days. So that is the most ridiculous argument in the world, right? When I hear worry about AFib, it doesn't even make sense, because we control the ventricular rate, not AFib. Everyone's going to go in and out of AFib. And do they need to be anticoagulated? No, that depends on the size, of course, of their atria, and the doctors listening understand that. The sooner you get the chest tube out, the lower the risk of AFib. If you have a digital air leak system that has continuous suction, as opposed to an analog system, which is off suction for an hour while you transport patients in the elevator, while you're switching from the bed to the unit, they get a chest full of clot, they're more likely to bleed. So we brought that in. They can all go home in 3 days, believe it or not. They really can, but you have to communicate with them. The keys are the social issues. So for the doctors listening, the ones in thoracic know that I FaceTime my patients at home. I look at their bathroom. I make sure they have an anti-slip mat. They have a bar in the bathroom, a bar by the commode, help at home, a daughter or son, and if not, an aide. And that gets set up. Our ACE patients are all elective. So that gets set up or I don't operate on them. So that's when they go home, they're going home to a safe environment in almost everybody. In cardiac, it's not as elective. The elective cases, you can do the same thing and it's inexcusable that we don't. But for the emergent ones, they're in the hospital for a few days, you have time to set up who they're going to go home to. Some people don't have internet. I get it. Some people can't get a scale. Some people don't have a cell phone. The world isn't perfect, but the vast majority do. And it's really up to you. If you're a great leader, you're going to take care of your patient when they leave the hospital, not just kick them out, because they're just going to come back and they're going to come back upset. So I think that all starts in the clinic. Who are they going home to? What is the environment? Are there stairs? Is there a railing on the staircase? Is there an anti-slip mat in the bathroom? That's a huge thing. I won't operate anyone unless they have an anti-slip mat in their shower. I mean it. And when I was in Birmingham, I had a few patients fall and get hurt. And I used to remember presenting it to my son. And I was giving my son a hard time about him being accountable for the bus being late. And he's, okay, Dad, you're accountable. I said, you know what? You're right. I am accountable for that. And I'm going to fix it. And that example went on and on. And so then I started making people get it back, because if we're going to lead, we should be accountable for everything. So I think that's what we have to learn how to do, and not make excuses when someone gets in a car accident post-operative day 41 and dies and said, it's not my fault. Well, maybe if you did a smaller operation and managed their pain better, they could have slammed on the brakes sooner and not got in that accident. So I think leaders look at data and don't make excuses and say that was unlucky. They look at it from a very different vantage point and say, is there anything I could have done to give that patient a better outcome? At our M&Ms, all I do is hear is, oh, I would have done the same thing. I'm like, great, the guy went home in a box, 6 feet under the ground. Probably we should have done something different. So that's not an acceptable answer. Let's try again. What would you have done differently? And we try to make it fun, and we know we're giggling like this, which is good. We try to make it fun and objective, but also we want to wrap our processes around best of outcomes. And when people say I've been doing it the same way for 10 years, that's the dumbest answer in the world, because you can't be better if you're doing something you did the same 10 days ago. And when a doctor tells me, quote, I don't feel comfortable, those are the most dangerous words in medicine. I don't feel comfortable, because my patient doesn't care about your level of comfortability, and I don't care about it. I care about them getting the best care in the world. If you don't feel comfortable, go work down the street in New York. There's a lot of hospitals here, but you can't work here for us. We want to get better every quarter. We make changes. We say this is best of class, and all 9 lung surgeons change to it. And that's the only way to do it. And people may not love it, but then this is not the place for them to work.
And do you have unified post-op protocols for your cardiac patients as well? Everyone treats AF the same? Everyone treats drain removal, wire removal the same?
No, and that's the point. We cannot get everyone to agree on that. Now, we have most of them, but there's a couple of older surgeons that are recalcitrant, and that's not optimal leadership. So we really should do it all the same way. Some of these do different operations, and they want to say it's differently, but it really not. Good is good, and we should all be doing it the same. Having said that, most of us do, and that's what helped us get to one. But we have lots of opportunities to get better. Let me make that very clear. We ain't good. We got a long way to go to get good.
So let's wrap up by looking forwards to the next 3 to 5 years in NYU Langone. What's the future there? What are you gonna, when I talk to you in 2030, what are you gonna tell me?
Well, so I always said it's really easy to get to the top. It's much harder to stay there, right? So, we were 1 last year, or tied with 1 last year, and now we're 1 alone this year. So that's 2 years in a row. Neurosurgery's been 4. Cardiac, this is their first year. As I mentioned to you, I say we want to do everything all the same, and we don't. Even prepping and draping, someone wants to use an extra drape. I hate that. Why can't we do it all the same? We shouldn't say, oh, Billy likes this and Sally likes that and Robert likes this, right? We should all be doing it the same way for things that don't matter. So we have opportunities not to just identify the best processes, but then to implement them and make sure everybody's following that, because ours are still only 70% penetrance. So I think we'll get better and better for that. And I'm getting a lot of interesting job offers right now. So I don't know where I'll be or what I'll be doing. But I know wherever it is, it's hopefully giving patients the best experience, the best operations, the best love, and the best care in the world. And doing everything minimally invasively with the shortest length of stay and the best outcomes. That's what it's about. That's what we all should be doing.
Yeah, well, absolutely phenomenal, completely inspirational as always. I encourage everybody to come and visit. I know you're very generous with your time and allow people to come and visit. And I really think, a lot of people don't believe what you say, but when you actually come and see it, it really is happening, and that's why you're
It
number one. So,
it does hurt me that people don't believe that we do everything robotically and everybody goes home in a day. But I think last year I had two people that spent more than one day out of 212 operations. So they really do. They really do.
yeah, yeah, amazing. Well, congratulations with this incredible effort. I mean, it really is amazing to be top in heart and lung surgery. And from all of us here at
Thank you.
CTSNet, a massive thank you for joining us. And we'd love to hear more from you. We want to see your operations. We want to see your best practice. So let's teach the world
And
about
Joel,
how to do good surgery.
and I just want to say, no one does that better than you, Joel. You're always on the cutting edge. You're always trying new things. You're always trying new robotic instruments, new ways to do surgery. So we should all embrace your vantage point of the world. And that is, let's try new things and get better and not say, quote, I don't feel comfortable.
Totally agree. Well, thank you
Yeah.
so much. And
All
thank
right,
you very
Joel.
much for joining us.
Thank you. God bless you, Joel. Bye bye.